And again, I'm very happy to welcome Professor Karim Kamal from Cairo, Professor of Anesthesiology and Critical Care from Cairo University. He will talk to us about intraoperative mechanical ventilation for the pediatric patient. And again, a very important subject.
مساء الخير. Thank you, Mr. Chairman, and I would like to thank the organizing committee for their amazing effort in organizing this wonderful conference. We are all very grateful for all the effort you have put in. It's a really great event, and thank you for allowing me to share in it. The topic of this lecture is intraoperative mechanical ventilation in pediatric patients. Anyone who has worked with children in the OR knows that pediatric anesthesia requires a very high level of precision and accuracy. You have to be very precise and accurate in everything you give and everything you do, because small errors in therapeutic interventions have the potential to cause either injury if you give too much, or inadequate effect if you give too little. And the smaller the patient, the greater the impact of these small errors. When you're dealing with a 4 or 3 kilogram child, it's different than when you are dealing with a 20 kilogram child. The smaller the child, the less the error, margin of error. For example, if you give medications or fluids to a 4 kilogram patient, you will have a 50% dosage error if you estimate the weight by 2 kilograms more or less. So if you're dealing with a 4 kilogram patient and you consider him to be weighing 6 kilograms, you'll give him 50% more fluids and 50% more dosage of any drug you give. This can be very problematic and disastrous. The same applies to mechanical ventilation, in which small changes in the delivered tidal volume can lead to unintended hyperventilation or hypoventilation or even injury to the lung. That's why you have to be very careful and have some degree of knowledge on how to ventilate a child in the OR. Now, we'll start with an everyday story that happens every day and can actually happen with any one of us. And the hero of the story is the anesthesiologist. We'll call him Dr. M. Dr. M, as you can see, has a very serious look. He takes his job very seriously, and he has a 10-year experience in anesthesia, mainly in adults, and he has a limited experience in pediatric anesthesia, mainly in adult tonsillectomies and hemiorrhagies. Now, Dr. M goes to work in the morning, and he looks at his list of procedures, and he starts doing his rounds and meeting his patients, and then he meets the second character in our story, which is Baby. We'll call him Baby O. Baby O is 2 months old. He weighs 5 kilograms, and unfortunately is suffering from biliary atresia, requiring a Kasr procedure. Of course, when Dr. M sees Baby O, he becomes very anxious. He doesn't deal with this age a lot. And suddenly he has so many questions in his mind. Which mode of ventilation should I use? How much tidal volume should I give? What's the pressure limit that I should adjust? What about the respiratory rate? Millions and millions of questions on how to deal with this child. And after a long period of time in thinking and planning, he reaches what he believes is the ideal plan on what to do. He would use an iris T-piece. Okay, that's the answer to his problem. He will just هيوصل iris T-piece وهينفخ للبيبي الساعتين بتوع العملية ويريح دماغه. Of course, this is not the right answer. I'm sure we can all agree that Baby O will be much better off put on a mechanical ventilator than being bagged with an iris T-piece. So, before we continue, we need to agree on one golden rule, and that will affect everything we talk about. Children are not little adults. Children are different from adults. They are different from the physiological point of view. They are different from the anatomical point of view. They are different. For example, they have a higher chest wall compliance, higher closing capacity, increased work of breathing, and increased oxygen consumption. and on the other hand, they have decreased function, residual capacity, decreased respiratory reserve, and decreased number of type 1 muscle cells in the diaphragm with easy fatigability of the respiratory effort. So they are different. The concepts you use in adult ventilation might not apply in pediatric ventilation. So you cannot deal with children that they are little adults. They are different. What are we going to talk about? We'll talk about two main issues. The first issue is pressure ventilation versus volume ventilation. What should I use? Pressure targeted ventilation or volume targeted ventilation? The second point is lung protective strategy. Does this apply in the pediatric or the anesthetized pediatric patient? We'll first start with pressure ventilation versus volume ventilation. When you anesthetize a child, most probably the anesthesia machine you will use will have these two distinct ventilatory modes. You will have pressure-controlled ventilation, which is a mode in which you adjust the inspiratory pressure and inspiratory time and the respiratory rate. You do not set a tidal volume, and the tidal volume is determined by the amount of pressure you use as well as the lung and chest wall compliance. The other mode is volume controlled ventilation. Here you set a tidal volume and an IE ratio and the respiratory rate, and the peak pressure is determined by how much volume you give and the compliance of the chest wall. So you do not set a pressure limit. What about this line, blue line in the middle? What is this? This is a pendulum. And I put it there because I wanted to illustrate to you that along the past 50 years, the trend between, or the trend on which ventilatory mode to use has shifted between these two modes repeatedly. The pendulum has started moving back and forth. Sorry. It's not showing here. There's something wrong with my computer. The pendulum started moving back and forth between the two modes over the past 50 years. And the trend has shifted between pressure ventilation and volume ventilation. This change in trend has started 60 years ago, or 50 years ago actually. It started with one of the landmark studies that have been published about ventilation of anesthetized patients in 1963 by Ben Dixon and his colleagues, that studied the impaired oxygenation that occurs in surgical patients during general anesthesia. What did they do? They studied 18 adult patients undergoing laparotomy procedures. All these patients were ventilated with pressure-targeted ventilation in the range of 15 to 20 centimeter water, and what they did was they monitored their oxygenation by looking at their PO2. What did they find? They found that the PO2 and the lung compliance of each of these patients decreased over time. As the surgery went on, their PO2 and their lung compliance went down. And that these changes could be reversed by hyperinflations of up to 40 centimeter water sustained for 15 seconds. Hyperinflations of 40 centimeter water sustained for 15 seconds. Does this sound familiar? ده بيشبهنا بحاجة اسمها recruitment maneuvers بنستعملها كلنا دلوقتي في المانجمنت of ARDS patients. فالحقيقة بان ديكسون والمجموعة اللي معايا دول كانوا سابقين عصرهم جدا، لأن هم ابتدوا يتكلموا عن الريكروتمنت من 50 سنة قبل ما أي حد تاني يتكلم عنه بتاع 40 سنة على الأقل. So you'd expect that the conclusion they reach from their results is that alveolar recruitment improves oxygenation. وكانوا يريحونا ويوصلوا للconclusion ده اللي الناس finally وصلت له. لكن unfortunately this is not the conclusion they came up from the study. What was their conclusion? Their conclusion was that large tidal volumes protect against falls in oxygen tension. This is what they came out with from their study, that large tidal volumes improve oxygenation and prevent the decrease in oxygen tension during anesthesia. So that led to that the pendulum started moving dramatically towards volume controlled ventilation. Everybody decided, okay, I'll use volume controlled ventilation. This will give me better oxygenation for the lungs. But after a while, people started to understand that there is a problem with volume controlled ventilation. What's this problem? To understand the problem, we need to look at this diagram showing the design of a traditional anesthesia ventilator. Now, as you can see, I don't know if the cursor is there. No, it's not. Okay, this, as you can see, I don't know if it won't. All right, there is the bellows, you can see on the right. These bellows compress the gas into the breathing circuit that delivers the gas into the lung of the patient. Now, as you can see, there are two problems in this design that caused the actual tidal volume that was delivered to the lungs of the child to be less than the set tidal volume. The first problem was this fresh gas flow inlet. The fresh gas flow inlet was placed, is this still working? Hello, Samani? Okay. The fresh gas flow inlet was placed between the bellows and the patient. So during inspiration, as the gas flowed through the breathing circuit, this gas was mixed with the gas coming from the fresh gas flow outlet. So the fresh gas flow mixed with the tidal volume, and this led to changes in the tidal volume delivered to the patient. The other problem was the circuit compliance. When the bellows compressed air into the breathing circuit and then to the patient's lungs, some of the gas was compressed inside the breathing circuit itself. And if the compliance of the circuit was high, the amount of gas compressed within the circuit was high. If the compliance of the circuit was low, the amount of gas compressed inside the circuit was low. But however low the compliance was, there was some volume that remained inside the circuit and did not reach the patient. So again, this affected the actual tidal volume that was delivered to the lungs of the child. So, as you can see, there was a problem. I'm setting a tidal volume, but a different tidal volume is delivered to the child. And this is very serious in pediatric ventilation. As you can see, I'm setting a tidal volume of 200, and the bellows are pushing 200 milliliter of gas into the circuit, but what is being delivered to the patient is only 97 milliliters. So there are 100 milliliters being lost inside the circuit. This is a very serious problem. So people decided, no, this is not working. Let's shift again to pressure controlled ventilation. Why? Because with pressure controlled ventilation, the tidal volume delivered depends purely on the set inspiratory pressure and the patient's lung thorax compliance. Circuit compliance, fresh gas flow changes, and even small leaks around an uncuffed endotracheal tube do not alter the delivered tidal volume. They have nothing to do with the delivered tidal volume. And in addition, the square wave pressure waveform provides maximum inspiratory pressure for the entire inspiratory cycle, inspiratory time, which favors lung recruitment and better distribution, as we just heard, of the anesthetic gas inside the lungs of the patient. And in addition, the inspiratory pressure is limited, thereby preventing barotrauma, and this is the very important point. So all of these are advantages of pressure controlled ventilation. But there are problems, and people starting seeing the problems of pressure controlled ventilation. The main problem was that a consistent tidal volume is not guaranteed. Any change in the lung or thorax compliance alters the tidal volume. And in surgical procedures in the abdomen or thorax, like laparoscopic procedures, which are likely to be associated with changes in lung and thorax compliance, there is fluctuation in the delivered tidal volume. And in small patients, these tidal volume fluctuations can be significant deviations from the intended tidal volume. We have all tried this. ممكن حضرتك تبقى مبنج طفل بpressure controlled ventilation وإذ فجأة تلاقي إن التايدال فوليوم اللي واصل للعيان قل جدا جدا جدا. ده بيبقى سببه إيه؟ يا إما المصل ريلاكسنت الإفكت بتاعه راح فابتدى الشيست وول كومبلاينس يقل، يا إما حد من الجراحين ضغط على صدر الطفل فزود البريشر فخلى إن الفنتليتر بيسايكل بسرعة. فزي ما احنا شايفين you cannot guarantee a certain tidal volume with pressure-controlled ventilation. And this, again, is a very serious issue. So people said, or pediatric anesthetists said, no, this is not working. We need to go back again to volume-controlled ventilation. But we need to find an answer to the problem we had, which was that the actual tidal volume was different from the set tidal volume. So they said, okay, we'll think about our problems. What are the problems that are causing this discrepancy? The problems are the interaction between fresh gas flow and tidal volume and the breathing circuit compliance. So they started thinking about the first problem. What about fresh gas flow? So they designed the modern anesthesia ventilators. Here, it looks different. As you can see, the piston delivering the tidal volume is placed towards the patient, while the fresh gas flow inlet is placed before the piston. And in addition to that, there is what is known as a fresh gas decoupling valve. This is a valve that closes during inspiration, and therefore it prevents any mixing between the fresh gas flow and the tidal volume delivered to the patient. So there is no more any mixing between fresh gas flow, any interaction between fresh gas flow and the tidal volume. This was the answer to the first problem, fresh gas decoupling valve. What about the breathing circuit compliance? The answer for this one was what is known as compliance compensation. What is compliance compensation? As you know, breathing circuit compliance, like we just said, is attributable to the compression of gas within the breathing system. The circuit compliance is expressed in milliliter per centimeter water, and the compliance can be multiplied by the inspiratory pressure to quantify the influence of circuit compliance on the delivered tidal volume. كلام يبان صعب لكن ممكن نبسطه لو ادينا example بسيط. Circuit compliance is equal, for example, to 5 milliliter per centimeter water. And if the inspiratory pressure that I reach is 20 centimeter water, the volume that will not reach the patient and will remain in the circuit is 5 times 20, which is equal to 100 milliliter. 100 milliliter in a child is a very significant amount of tidal volume. So, the modern anesthesia ventilators perform what is known as a pre-use compliance test that measures the circuit compliance, and accordingly, the ventilator is able to assess the volume lost due to compliance and compensate for it during tidal volume delivery. So, if you look at this modern anesthesia machine, I want to set a tidal volume of 200. So, the ventilator does a pre-use test and determines that 140 milliliter will be compressed inside the circuit. So, it delivers 340 milliliter inside the circuit so that what reaches the patient is the 200 milliliters that I want him to receive. And this is called compliance compensation. I hope it's clear. Okay, so we have the answers to our two problems, and therefore tidal volumes as low as 20 milliliter can be accurately delivered using volume controlled ventilation. So now it sounds perfect. We are reaching very low tidal volumes in a very accurate way. So I'm sure that the pendulum should stop swinging, but unfortunately it didn't stop swinging. Why? Because there came another problem, which is peak inspiratory pressure. High peak inspiratory pressure can be very harmful, especially in children with lung injury. With volume-controlled ventilation, you have the risk of generating a very high level of peak inspiratory pressure, especially if the child coughs or there is a decrease in thoracic compliance for any reason. And this high peak inspiratory pressure can be very harmful. Erickson and his colleagues did an observational study on pediatric patients with acute lung injury and found that there is a direct relationship between peak inspiratory pressure and mortality. Kimani as well, they did a retrospective study on children with acute hypoxemic respiratory failure and found that higher peak inspiratory pressure was found in non-survivors compared to survivors, which again means that there is a link or a relationship, a direct relationship between high peak inspiratory pressure and mortality. So pressure limitation is of great importance in pediatric ventilation. So the pediatric anesthetist started thinking, I need pressure limiting. to avoid the problems caused by high peak inspiratory pressure. And at the same time, I need volume guarantee to prevent any fluctuation in tidal volume. If I use pressure controlled ventilation, I will get pressure limiting, but I will not get a constant tidal volume. If I use volume controlled ventilation, I will get a volume guarantee, but I will not get pressure limiting. So I need a mode of ventilation that combines both. So the anesthesia machine manufacturers started thinking, and the pendulum started moving again, but this time it stopped in the middle because they invented what is known as pressure controlled volume guarantee. What is pressure controlled volume guarantee? It is a mode in which the ventilator measures the patient's lung compliance on a breath-to-breath basis, then determines the pressure required to be given during the set inspiratory time to achieve the set tidal volume. I am setting a tidal volume of 200. The ventilator measures the compliance and says that I need this level of pressure, 20 centimeter water, for example, so that the patient can receive the 200 milliliter tidal volume that I'm setting. As a result, the ventilator can deliver a square wave pressure waveform with no high peak inspiratory pressure and better distribution of gas, like we see in the pressure controlled ventilation, and also ensure that a constant tidal volume is delivered to the patient like volume controlled ventilation. So you are getting the best of both modes. Because there is a volume target, of course, the pressure will change if lung compliance changes. And this mode of ventilation is currently the best mode to use in pediatric ventilation. Okay, so has the pendulum stopped moving? I think for the time being, at least it has, but nobody knows what will happen in the future. What about lung protective strategy? Just a few words about what lung protective strategy is. In the traditional approach to mechanical ventilation, high tidal volumes were used, 10 to 12 milliliter per kg. That caused alveolar overdistension. This alveolar overdistension caused a lot of trauma to the lung, volutrauma and barotrauma, and lung injury very similar to in morphology to the lung injury caused by ARDS itself. And also there was the use of zero end expiratory pressure. This led to the problem of alveolar collapse at the end of expiration, which led to more increased in shunt fraction, more hypoxemia, as well as the repetitive opening and closure of alveoli, which led to what is known as atelectotrauma because of the activation of the inflammatory cascade and lung injury. So all of this trauma, the volutrauma and barotrauma caused by alveolar overdistension, and the atelectotrauma caused by alveolar collapse, all of this constituted what is known as ventilator-induced lung injury, which is a very serious issue. You are putting the patient on the ventilator to help him, not to cause him more injury. So they started, or intensivists started thinking of a strategy in which they can ventilate the lung without causing it any more injury, which is known as lung protective strategy. So they thought we have two problems, we need to face them: alveolar overdistension and alveolar collapse. For alveolar overdistension, they said, okay, we'll use low tidal volume ventilation, 4 to 8 milliliter per kg. For alveolar collapse, they said, and this also increased the problem of alveolar collapse. And for alveolar collapse, they said, okay, we will use PEEP instead of ZEEP, positive end expiratory pressure, as well as recruitment maneuvers, and this together is known as lung recruitment. So these were the answers, or this is what compromises or describes the lung protective strategy. There are many very important trials that have talked about this and showed the importance of this strategy. Most important one, or one of the most important ones, is the study or trial published by the ARDS network in the year 2000, and they categorize patients or randomly allocate patients to either receive a tidal volume of 12 milliliter per kg with a plateau pressure of around 50 centimeter water, or a low tidal volume of 6 milliliter per kg and a plateau pressure of 30 centimeter water. And what they found was that the low tidal volume group was associated with decreased mortality and increased number of days without ventilator use. Another very important trial was the one performed by Villar in 2006. They used a tidal volume of 9 to 11 milliliter per kg with a PEEP of 5 centimeter water in one group, and in the other group a tidal volume of 5 to 8 milliliter per kg and a PEEP of P-flex plus 2 centimeter water. And again, The low tidal volume, high PEEP group was associated with decreased mortality, increased number of ventilator-free days, decreased non-pulmonary organ dysfunction. All of this is in ARDS patients and acute lung injury patients. What about anesthetized patients? There is a systematic review published, or a meta-analysis published in 2015 that talked about the effect of lung protective ventilation with low tidal volume on clinical outcomes in patients undergoing surgery. We're talking here about adult patients. So there were 19 RCTs involving 1,348 adult anesthetized patients. The intervention group received lung protective ventilation with low tidal volume. In comparison, the comparison group received conventional ventilation with 8 to 12 high tidal volume. The conclusion was that lung protective ventilation with lower tidal volume was associated with a lower risk of lung injury and pulmonary infection. So lung protective ventilation supposedly works in other patients, whether critically ill with ARDS or acute lung injury, and as well as anesthetized adult patients. But here we come to the same question. Children are not little adults. Does lung protective strategy benefit the child as well as the adult? Well, actually, the relevance of ventilator-induced lung injury in the pediatric population is still very controversial. There are studies, very few studies published, and they have very conflicting results. For example, PLOTS in 2012 studied 12 infants without pre-existing lung injury undergoing cardiac catheterization, and they received 2 hours of elective ventilation using a tidal volume of 10 milliliter per kg, and they found that all patients showed profound pulmonary inflammatory response. They found lung injury starting to happen. On the other hand, Erickson in 2007 did an observational study on 117 acute lung injury pediatric patients, and they stated that the higher maximum and median tidal volumes were associated with reduced mortality even when corrected for severity of lung disease. So we have people saying that large tidal volumes did injury to the lung, and we have groups saying that large tidal volumes decrease mortality. So it is very confusing. There was a systematic analysis, or systematic review and meta-analysis published in 2014 that involved 8 studies reporting mortality in mechanically ventilated pediatric ICU patients, and a total of 1,700 pediatric patients, all below the age of 18 years with a mean age of less than 5 years. What did they find? They found that there was no association between tidal volume and mortality, and that comparing patients ventilated with tidal volumes below 7 milliliter or 8 milliliter per kg with patients ventilated with more than 10 or 12 milliliter per kg showed no association between tidal volume and mortality, as I said, and that limiting the analysis even to patients with acute lung injury or ARDS did not change these results. So clearly, the issue is not that strong. The effect of tidal volume on mortality is not that clear in pediatrics like it is in adults. So the conclusion, a relationship between tidal volume and mortality in mechanically ventilated children could not be identified, irrespective of the severity of the disease. This is all very confusing. We have adult studies, we have pediatric studies, we have ARDS patients, we have anesthetized patients. في الآخر كده, how much tidal volume should we use in anesthetized children? Well, based on the available pediatric data, which is not very much, targeting a tidal volume between 6 and 10 milliliter per kg is considered safe. A tidal volume of more than 10 milliliter per kg should be avoided, but you have to remember that the sicker the lung, the smaller the allowable tidal volume. Just one or a few words about PEEP. PEEP is an important part of the lung protective ventilation approach, aiming at preventing atelectasis trauma. However, the very few studies about PEEP in pediatrics show that the optimal PEEP level is still unclear for the pediatric population. One recommendation is to routinely set the level of PEEP at 5 centimeter water. This range should be safe and prevent atelectasis in most surgical patients. Higher level of PEEPs may be necessary if there is chest wall stiffening or lung injury. One of the very few studies about PEEP in anesthetized children that I found was this one. It's a very interesting result. Talks about the impact of PEEP on functional individual capacity in anesthetized children exposed to high levels of inspired oxygen. The hypothesis behind the study was that the use of high FiO2 results in resorption at atelectasis. Therefore, if you use an FiO2 of 1, this results in the decrease in functional residual capacity compared to the use of an FiO2 of 0.3, and that this decrease can be prevented by using a PEEP of 6 centimeter water compared to a PEEP of 3 centimeter water. So they tested the hypothesis and they found it to be true. A PEEP of 3 centimeter water was insufficient to prevent the decrease in functional residual capacity when using an FiO2 of 1, but a PEEP of 6 centimeter water effectively counterbalances the negative effects on functional residual capacity even at high levels of oxygen. So, to sum up what we said, adjusting ventilation settings in children should be done very carefully to avoid hypo or hyperventilation as well as lung injury. What applies to adults does not necessarily apply to children. Volume control ventilation delivers a constant tidal volume, but at the risk of high peak inspiratory pressure. Pressure control ventilation maintains a safe pressure limit, but does not guarantee a fixed tidal volume. Pressure control volume guarantee is the best mode currently available for use with anesthetized children. There is currently no evidence to support the association between high tidal volume and mortality in pediatric patients. This may be due to that children are less susceptible to ventilator-induced lung injury than adults. A tidal volume of 6 to 10 milliliter per kg is considered safe to use in anesthetized children. And finally, applying a PEEP of 5 centimeter water can be beneficial, especially if high FiO2 is used. Thank you.
Thank you, Karim, for a very nice and very illustrative talk. Any question? Do we have a predicted body weight for children like an adult, or we use the actual body weight to calculate the tidal volume?
Most of the studies that talked about the ventilation or the idea of whether lung protection or whatever use the actual body weight. They didn't use either ideal or predicted. They used the actual. So I'm assuming that using the ideal body weight would be the answer, but most of them use the actual body weight of the children.
Thank you, Karim.